आप इंटरेस्ट से बोल रहे हो आप अपना डिस्कशन योर्स ज्यादा इंटरेक्शन करने के लिए बोले आप यू कैन ब्लॉक अस इंटरप्ट अस एंड आस्क क्वेश्चंस आल्सो ये कर लीजिए कैमरा फोकस करिए गैलरी देखा वाला डाल दो उसमें पार्टिसिपेंट दिखा दो Okay, so good morning, audio on.
Yes.
Good morning to all our ECCS HGPJ partners. Today we have the team from microbiology, but before I hand over the session to them, I like to also find out our routine business affairs that how is this week since we last met on Wednesday regarding this your corona patient load. So I like volunteers to come and talk about it. Dr. I can see Manju Pandey, I could see Dr. Shukla, I can see Dr. Sujit Yadav. So can you just tell me about two things? One is you have reports coming up, and we also realize that patients are, there is a downward trend. We can see the downward trend in the attendance of the patients in COVID hospital. And whatever patients we are getting are mostly now very serious patients, which requires a really RCH SGPJ care actually. But regarding the number of cases detected by testing, I think microbiology team will tell you how the trend is happening. But what is more important to also to know that during this process of care, in especially UP, we have learned a lot of things regarding the testings. So microbiology team is going to tell you everything about that in addition to some of this general information to you and national as well as global situation. So Dr. Manju, you have been participating regularly. Lalita, you are there. You are our primary hub in Meerut. So what is the trend happening in your place? Is the trend is coming down? Because last time you told us that something is looking positive. So how do you think about it? Your audio is not. Please make your audio unmuted. Yes, go ahead.
Sir. Yes, sir. Certainly, it's going down now. As usually 100 plus is coming still.
Yeah, 100 plus
because in last days it was touched the 200 plus.
But out of 100 plus, because you are a primary hub, so you are also getting referral patients. Out of 100 plus, how many are sick patients requiring ICU care or will multi-system complications? How many are percentage-wise out of 100?
Sir, out of 100, sir, these are in the total in Meerut, like L1, L2, and L3, all.
Okay. So you mean all L1, L2, L3 all together?
Yes, sir. Together.
So what is the Meerut population? Your attendance in Meerut Hospital?
Yes, sir.
Daily attendance of admissions. Yeah.
Pardon, sir?
In Meerut, how many patients you are admitting every day?
Every day, sir, it comes in our college, maybe 20, 30, and we have started 2 ICU. One is, earlier it was, we have made it for 40. Now it is for 70.
So that means whatever I just said in my introduction today, you are getting more sick patients like us. More sick patients.
Yes, sir. Nowadays.
Though the overall numbers are coming down, but the number of sick patients are more. Even same region also, we have also increased our ICU beds. Also, we expanded our ICU beds. So naturally, what is happening is more and more cases are going for home isolation, etc. So that is the trend why you are not getting much patients in hospital. But the serious patients requiring ventilator care or
sir,
yeah, go ahead.
Sir, one thing I want to add, sir, because of some private hospitals are started the COVID treatment, so the patients are going to the private hospitals and being nearby to Delhi, so many of them those can afford, so they are going to Delhi.
Yeah, that's a very right kind of
Yes, sir.
observation that we have seen, because one of our residents' parents belongs to Mirror, they have shifted the patient to Delhi. So that's good. I mean, but overall, very difficult to say that in one hospital situation we cannot compare, saying that how the trend has come down. We are still alert, and we are maintaining our same spirit in terms of the capacity building, in terms of the making available the ICU beds or isolation beds or oxygen therapy requirements, etc. We all are prepared for that. So we should not actually feel kind of relieved. I mean, the situation has not come to that extent. I think I've been the microbiology team will definitely let us know what is happening into the trend of the positivity rates and their impact in admission, etc. So I think we'll go over to the microbiology team. So we have the team. Actually, we have prepared many lectures for the microbiology side, but we are planning to make it split to 2 or 3 sessions so that we can talk about in detail about each aspect. So we have announced the topic for today. So it is broadly 2 areas that are going to cover. So we have a team of 3 people coming from microbiology. So I'll hand over this session to them, and please go ahead to present your cases. And you can interrupt them in between also and ask them and clarify from anything you want. Another
Good morning, everyone. I'm myself Dr. Atul Garg. I'm assistant professor in Department of Microbiology. I'll be discussing about SARS coronavirus 2, its virology, transmission, dynamics, and Indian data. I have been informed that most of the participants are clinicians, so I'll try to make my talk as clinically oriented as possible. I'll try not to teach much theory, और जो theory discuss करेंगे उसका भी practical clinical relevance साथ साथ discuss करते हुए चलेंगे. And please feel free to interrupt me in between जहाँ पे कोई भी problem हो या कुछ समझ में नहीं आए तो. Okay, starting with the classification. SARS coronavirus 2, it belongs to family Coronavirinae, and there are 4 genus in this Coronavirinae virus: alpha coronavirus, beta coronavirus, gamma coronavirus, and delta coronavirus. Then in beta coronavirus, we have 2 subgenus, sarbecovirus and merbecovirus. In sarbecovirus, we have, in 2002, we have SARS coronavirus from Guangdong province. Then this is SARS coronavirus 2, which is the recent coronavirus. And this MERS coronavirus, this belongs to a separate subgenus. Coming to human coronavirus, till date 7 human coronavirus have been identified, and based on their pathogenicity, they have been divided into mildly pathogenic human coronavirus and highly pathogenic coronavirus. Mildly pathogenic coronavirus, in fact, upper respiratory tract and cause seasonal flu-like illness. They consist of human coronavirus 229E, O43, NL63, and HKU. Whereas highly pathogenic coronavirus, they infect the lower respiratory tract, and they are the primary cause of pneumonia, ARDS, and complications. It consists of 3 viruses: severe acute respiratory syndromes or SARS coronavirus, then Middle East respiratory syndrome coronavirus or MERS coronavirus, and last one is the latest novel coronavirus, that is SARS-2, that is severe acute respiratory syndrome coronavirus 2. Coming to the evolution of this virus, coronavirus, they are mainly of zoonotic origins. All the coronavirus, 3 coronavirus, these have been originated from the bat. They were bat coronavirus. Through an intermediate animal host, they were transmitted to humans. Like this, through civet cats in 2002, the SARS coronavirus was transmitted, and there was a pandemic which originated from China. 10 years later, that is in 2012, through camel intermediate host. MERS coronavirus originated in Saudi Arabia. 7 years later, in 2019, through the intermediate, we are not sure whether there was snails or porcine or porcupine. There are a lot of theories about it, but this virus has been originated in 2019 from Wuhan, China. So every 7 to 10 years, a virus is originating. We really don't know after 7 to 10 years what will happen. This is about the origin of my colleague Dr. Chinmay Sahu will be covering the international epidemiology and current aspects. So I'll be skipping the part on the global epidemiology. This virus was originated or first time isolated from Wuhan, China. This is the timeline. These type of slides you all must have seen that somewhere in December 30, there was a cluster of case which was identified in China. In 7 days, the virus was cultured by CDC China. In next 5 days, the whole genome sequencing was done and we could know that yes, it's a SARS coronavirus. And within January, almost 8 to 10 countries it has already spread, and by March we had a global pandemic. Okay. Now, after this brief introduction, coming to the first part of my talk, that is the basic virology. Structure of SARS coronavirus. The size of a coronavirus is 100 to 150 nanometers. Striking features are club-shaped spikes, giving the name coronavirus because of the crown-like appearance under electron microscope. These are the club-shaped spikes. Because of these spikes, when seen under electron microscope, it is known as coronavirus. The genome of this virus is 26,000 to 32,000 base pairs. This is the structure. It is a RNA virus. This is RNA. Then this is the nucleocapsid proteins. Then this is envelope proteins, membrane proteins, and spike glycoproteins. As a clinician, you should be aware because spike virus attached with spike glycoproteins, and I look for antibodies against spike glycoproteins when I am looking for a plasma donor. That is the importance of spike glycoprotein. Envelope proteins and membrane proteins, these are the targets in a PCR, the genes which prepares them. So these all, as a clinician, we are supposed to know. Coming to the genomic structure. Genomic structure is important for you to understand. I'll try to be very brief and I'll try to be exact point wise. What exactly is the genomic structure relevance to you, because you need to understand the genomic structure, because the next class will be on lab diagnosis. Until and unless we know the genomic structure, we won't know what we are targeting in a lab diagnosis, because the basic of diagnosis is PCR, real-time PCR, in which we are targeting some genes. Now, this is the whole genome of the virus. 1/3 of the genome is structural proteins. This colored part, this is the 1/3 part. These are the structural proteins, which consist of, these are the genes for envelope protein, membrane protein, N proteins, and this is open reading frame 1A, open reading frame 1B. Now this forms 2/3 of the genome. Now it is important to understand that this part, open reading frame 1A and 1B, is highly conserved for SARS coronavirus 2. These genes are genus specific. So they can be found in SARS coronavirus 2, they can be found in other coronavirus also. So whenever we do a PCR, generally we target a screening gene from this area. If the screening gene has been found in the sample, we target a confirmatory PCR by one of the genes from this area. In this area, we have RDRP gene in ORF1B and ORF1A. We target one of these. This is the size, like the whole genome is about 30,000. 21,000 is the open reading frame. Open reading frame with the two targets, ORF1A, ORF1B, and RNA dependent RNA polymerase RDRP. These three genes are targeted as confirmatory PCR, and these E gene, M gene, N gene, S gene, these are found in screening PCR. So whenever we do a PCR, this area is genus specific, this area is species specific. So we do a screening genus specific PCR. If the sample is positive, we do a species specific PCR. These are the structural proteins. I won't go in much details of the structural proteins, but this is the S protein. S protein consists of two parts, S1 and S2, and antibodies against with the S protein, it attaches to ACE receptors, and antibodies against this S protein are protective in nature, they are neutralizing, and they are targeted in plasma therapy. Okay. Now coming to the clinical importance, why I have shown you this genetic structure, so that when the next class we talk about the lab diagnosis, things are clear. Now in the genetic structure, I have shown you two things. One is the whole genome is of 30,000 base pairs, then of which 21,000 is highly conserved region, and about 9,000 is the genus specific area, in which there are certain screening genes. In the genus specific area, we have S gene or E gene or N gene, which can be used in a screening PCR, whereas RDRP gene, ORF1A and ORF1B, these are all highly conserved genes and they are used for confirmatory PCR. Now this genetic structure is important to a clinician because there are three types of molecular tests which are available in Indian market. One is the real-time PCR, which is done by most of the government labs, which is a two-step procedure. We do a screening PCR followed by confirmatory PCR. Second is TrueNat. TrueNat consists of two-step PCR. And third is CBNat. CBNat full form is cartilage-based nucleic acid amplification test, or it is the Gene Expert COVID PCR test also. The machine is of Gene Expert. Cepheid is the manufacturer, US brand, and the test is known as CBNat. Now the questions are, what are the target sites? Okay. In ICMR protocol, we do a screening E gene PCR followed by confirmation. In TrueNat, generally because these tests are done in a government lab, you get a clear cut. Sometimes we get a lot of request and question from our clinician friends who are working in private sector. Report आ गई है, ये gene positive लिखा है, ये gene negative लिखा है, इसका क्या interpretation है? So lab should not do such thing clear cut, because whenever a sample is sent, a COVID query sample is sent, तो clear होना चाहिए कि positive है कि negative है, क्या है. But कई बार ऐसा होता है, गवर्नमेंट प्रेशर्स होते हैं, टेक्निकल उनके जो भी होता है, रिपोर्टिंग पैटर्न्स होता है. Like especially it happens in TrueNat. In TrueNat we do a first screening E gene PCR. E gene PCR अगर positive आता है, we confirm it by RDRP PCR. If a PCR is both E gene positive and RDRP positive, it is COVID positive. If it is E gene positive and RDRP negative, then it is COVID negative. तो ये क्लियर कट लिखना चाहिए, बट समटाइम्स लैब बहुत बार ऐसा होता है सिर्फ ई जीन करके रिपोर्ट दे देते हैं कि नेगेटिव या पॉजिटिव फॉर ई जीन, आरडीआरपी करते ही नहीं है. So all these things happen. The last is CBNat. CBNat is a good test. It targets 2 gene, E gene and N gene, and simultaneously E gene and N gene को डिटेक्ट करते हैं, इसके बेसिस पे रिपोर्ट देते हैं. कई बार CBNat की रिपोर्ट्स के लिए फोन आता है कि COVID E gene and N gene not detected and RNA speed gene detected. इसका क्या मतलब है? किसी भी PCR में RNA speed gene detected means वो internal control है. Lab should not write all these things. They should be very clear. Like in SGPJ we write either positive or not detected. ये सब queries gene नहीं लिखनी चाहिए. The clinician gets unnecessarily confused. Okay. Coming to the second part. Before I come to the second part, if you have any queries regarding this virology या कुछ, so you are free to ask. Otherwise, I'll move to second part. Okay, coming to the second part, routes of transmission. It is the SARS coronavirus to the positive variant of COVID-19 can be transmitted by droplets. The most common method is droplet. Second is by contact. Contact can be direct contact or indirect contact. And last, it can be by aerosols also. So droplet transmission, we all know, they are respiratory droplets. Generally, their size is more than 5 micrometer. And whenever the person sneezes, coughs, these type of aerosols, droplets are generated. Second is airborne transmission. This topic is slightly controversial because WHO till date maintains the status that there is no airborne transmission with SARS coronavirus 2, but it has been documented in literature. It has been documented experimentally by some of the labs by generating aerosols. Yes, the virus can remain suspended up to 3 hours, but till date, no culturable virus have been isolated from an air sample by any lab in the world. Third is the contact. It can be direct contact or indirect contact. In indirect contact, this is a classical paper from NAGM. Everybody is using their data only. There is one paper which says that plastic and stainless steel, the virus can stay for 3 days, cardboard for 24 hours, copper for 4 hours. So at room temperature, the virus can be maximum be alive for 3 days. उसके बाद मर जाता है. On refrigeration or lower temperature, viable virus can survive for a long time. Other modes of transmission can be there. However, there are no authentic published report like in feces, urine, plasma, breast milk, vertical transmission. These mechanisms have been hypothesized. Breast milk, recently a study has come in JAMA America publication. What they did was they collected the breast milk and did a PCR. 3 of the milk samples were positive by PCR, but on culture all the samples were negative. So they concluded that the milk doesn't transmit a viable virus. This whatever PCR is positive, it can be a skin contamination, or probably the child which was sucking the mother's breast, from the child the virus has come into the milk. Okay. Now coming to the practical aspects of transmission dynamics, especially for clinicians, there are certain questions which we are hounded every day, and we should have a clear-cut answers. When is COVID-19 patient most infectious? First, how long is a patient infectious? What is the current discharge policy? This you all know. Are there viral load difference between asymptomatic and symptomatic patient? And what is the correlation of CT values with COVID-19 transmission? Okay, coming to the first question, when is patient most infectious? The answer is the patient is maximum virus shedding occurs 5 to 8 hours before onset of symptom. This is the day 0 of onset of symptom. The maximum virus shedding is occurring just before the onset of symptom. So we can safely conclude that the patient is infectious 48 hours before the appearance of symptoms, and for next 4 to 5 days the viral loads are pretty high. By day 6, by day 7 the viral loads go down, and by day 8 the virus is not detectable. So when a symptomatic patient is highly infectious for next few days. Now this is a data from, this is the unpublished data from CDC Atlanta by Midgley et al. They have done a Kaplan-Meier analysis. They have cultured the virus, and in their, it's a big article. Finally, what they have concluded that although the PCR was positive till day 30, a lot of samples, but after day 9 they were not able to culture any virus. So we don't have a viable virus transmission after day 9. By 50% day 4 पे decrease कर गया, and day 9 पे 100% viable virus decrease कर गया, as documented by culture. Although PCR documented nucleic acid only, PCR can remain positive, and one of the publications, the PCR is positive even up to 12 weeks. 3-4 महीने तक भी PCR positive, 84 days तक भी होता है. The PCR can be positive because PCR is a very sensitive test. Even if it is a dead virus or if it is a broken virus and nucleic acid is there, the PCR will come out to be positive. Discharge policy, we all know that after 10 days in an asymptomatic patient we discharge. Okay. The next question was, is asymptomatic patient less infectious than a symptomatic patient or more infectious? So this is a paper from JAMA Internal Medicine from August issue. This is a paper from Korea based on 303 patient study. I'll directly come to the conclusion that the cycle threshold values for asymptomatic were similar to symptomatic patients. That is, the viral loads in symptomatic patients and asymptomatic patients were equal. So we cannot say that asymptomatic patients are less infectious. Okay, coming to the last, what is the correlation of CT value with COVID-19 transmission? See, we need to understand the basic concept of CT value. Generally, we in a COVID-19 PCR, we extract the nucleic acid of the virus and we amplify the virus. So one RNA will get, and to multiply the virus in a machine, that is polymerase chain reaction test, and one cycle, one virus will convert, one nucleic acid will convert to 2 nucleic acid. In 2 cycles 2 will convert into 4, in 3 cycles it will convert into 8, in 4 cycles it will convert into 16. So exponential n to power 2 के हिसाब से ये बढ़ता रहता है nucleic acid. So and as the amount of nucleic acid is amplified, it reach a value after which it can be detected by our machine. So एक threshold होता है कि nucleic acid जैसे उस value के ऊपर पहुंचता है, threshold के ऊपर machine उसको detect कर लेती है. जिस point पे कि अब उस point पे कितनी cycles में पहुंच रहा है. अगर initial viral load patient में ज्यादा होगा तो वो threshold फटाफट पहुंच जाएगा, CT value low होगी. Whereas viral load patient में कम होगा तो CT value high होगी. So 13 और 14 are the generally high CT values and 36, 37 are the lower CT values and 40 के बाद तो sample को negative declare कर देते हैं. So theoretically we can say that CT values correlate with the viral loads, but practically it is not as such, because in a given PCR the most important step is the sample collection. If a good quality nasopharyngeal swab has not been collected, viral load ऐसे oral swab में आधा होता है nasopharyngeal के, then cold chain maintain हुआ था कि नहीं हुआ था, then automated extraction था RNA का कि manual था, automated is a better one, then machine कौन सी use कर रहे हैं PCR के लिए, then kit की sensitivity क्या है, and last how capable is the technician. So there are at least 7 to 8 variables जिसके ऊपर CT value depend करता है. When there are so many variables in a given test, then that test cannot be used for the quantitative purposes. So जितने भी टेस्ट है कोविड के सारे क्वालिटेटिव टेस्ट हैं, and these are the ICMR guidelines. ICMR ने भी advisory दिया हुआ है कि CT values have no role in viral loads detection in current scenario. So again, when is the patient most infectious? Just before the development of symptom. How long is patient infectious? Patient is infectious for day 9 to day 10. After 10 days, the patient is practically non-infectious and can easily roam in his house. What a current hospital discharge policy? 10 days. Are there viral load difference between asymptomatic and symptomatic patients? No. What is correlation of CT value with COVID-19 transmission? No rule as such. Okay. Coming to the third part of my talk, that is Indian data on COVID-19. If you have any queries, you are free to ask me. Otherwise, I'll continue. Okay, coming to the third part. This is that ICMR data. This is data of 12th October. Number of tests done till date, approximately 9 crore tests have been done in India, and every day we are doing about 11 lakh tests. Current Indian capacity is of 11 lakh tests, and till date 9 crore samples have been tested in India. Of the 9 crore samples which have been tested in India, almost 72 lakh samples have been turned out to be positive. So the positivity rate in India is about 8%. Of the 72 lakh samples, the death is about 1,09,000 deaths. Okay, so the case fatality rates come out to be 1.5%, which is pretty low as compared to Western data, and recovery rate is 86%. This data is important. This the ICU, the patients who are critically ill and requiring treatment, it is only 0.1% in India. This is the Indian data, that 71,75,000 COVID positive patients are there in India. Maximum number of cases are from Maharashtra. Of the 71 lakhs, almost 15.5 lakh are from Maharashtra. 25% तो अकेले महाराष्ट्र से ही हैं, followed by Maharashtra, Karnataka, Andhra, Tamil Nadu, and UP. UP is number 5. UP, Uttar Pradesh में 4,39,000 COVID positive patients have been reported till date. This is a COVID map which आजकल ये WhatsApp पे सब बहुत share हो रहा है कि we have already crossed the peak and there is a downward trend. Trend clear cut दिख रहा है. This is the data which was released yesterday by Ministry of Health. Weekly data इन लोगों ने करा है. This is the weekly data. This is in second week of September. On a per day average, 92,000 cases were reported, which fell down, and currently about 72,000 COVID patients are reported positive every day. Okay, coming into the last, since we are covering Uttar Pradesh, so I have collected UP data. First is about the testing capacity. The first case at our PGI was in March. In March, we have only one lab in India, that is in UP. KGMC Lucknow was the only lab, and with time now, currently there are 130 labs which are testing. We मेडिकल कॉलेज लैब डूइंग RT-PCR और अ डिस्ट्रिक्ट हॉस्पिटल लैब TrueNet 130 में सब कुछ इंक्लूडेड है. ओके, दिस इज वीकली एवरेज देखते हैं. लाइक लेट्स सी, दिस इज 15 सितंबर को वी हैव टेस्टेड 1,45,000 सैंपल्स इन यूपी एंड almost 6,500 were positive. Now this is the data from UP. Till date we have tested 1,25,00,000 samples have been tested in UP till date, of which 4,73,000 are positive. These are the positivity. In UP the total positivity rate is 3.9 or 4%. The total positivity rate, as we have discussed, for India is 8. India में 8% का positivity rate है, but UP में 4% का हमारा पॉजिटिविटी रेट है. ये रेट ऑफ इन्फेक्शन है जो सारे कॉलेजेस का है अलग अलग. ओके, किसका कितना है, ये आर्मी कमांड हॉस्पिटल का सबसे ज्यादा रेट है, बिकॉज ये अपना दे डोंट टेस्ट डिस्ट्रिक्ट सैंपल्स, दे आर जस्ट टेस्टिंग फॉर देयर आर्मी सैंपल्स. ओके, थैंक यू वेरी मच. WHO warns we are in a corona infodemic, an epidemic of too much information. तो आजकल इतना ज्यादा इंफॉर्मेशन अवेलेबल है, we actually need to analyze and see कि the information is from a authentic source like WHO, CDC Atlanta or a good reputed journal like Lancet, Nature, JAMA. आजकल मटेरियल आ रहा है, it becomes every day the things are changing. Thank you very much. If you have any questions you can ask. Fine. I'll now hand over the program to Dr. Chinmay Sahu, the Associate Professor in Department of Microbiology at SGPJ. He'll be covering the international epidemiology part.
अरे यार मैं तुम्हें किया था वैसा वो नहीं है, सीएमई में हूँ यार. बात है
Good morning to all. Now about the global data about COVID-19. This I am skipping because we know that the SARS coronavirus 2 comes under the coronavirus family. This I am skipping. You are already been covered. So how the virus originated, more or less all know, but to recapitulate. In December 2019, in Wuhan, Hubei province, China became the center of an outbreak of pneumonia of unknown cause. And all the cases shared history of exposure to the Wuhan seafood market, where various kinds of wild animals were in sale, including poultry, bats, and marmots. And the wet and dirty environment provides favorable conditions for the virus to survive and reproduce. In 31st December 2019, the local health authorities of Wuhan, they issued an epidemiological alert and market was shut down on 1st January 2020. 59 suspected cases of pneumonia were transferred to a designated hospital starting from 31st December 2019. And on 2nd January 2020, 41 admitted patients were identified as a laboratory confirmed case of novel coronavirus using real-time PCR and next generation sequencing. So the 31st December 2019, Wuhan notes 27 pneumonia cases. To 8 December 2019, 8 January, China Center Disease of Control and Prevention announces a novel coronavirus isolated from the Wuhan pneumonia patient. 10 January, first genome was released by the China in Gene Bank. 30th January, WHO declares it a public health emergency of international concern. On 11th February 2020, WHO names the disease as COVID-19 and the virus was named as SARS coronavirus 2. And on 11 March 2020, WHO declares COVID-19 as a pandemic. So since then, what happened to China cases? The maximum number, we can see that the maximum explosive number of cases were seen during the January and February. After that, all the cases in China has decreased, and now only handful of cases, 2 to 3 cases per day, can be seen from the China. But now, on yesterday, the top 10 countries reporting the new coronavirus cases. First is US, United States of America. Second, India, Brazil, Russian Federation, Colombia, Argentina, Spain, Peru, Mexico, and France. Among the but total cumulative cases is highest in United States, but number of new cases reported in last 24 hours, maximum number of cases were reported from India. Although the cases are decreasing in India, still we are reporting highest number of cases, new cases per day, followed by US, Brazil, Russian Federation, Colombia, and other countries. All other countries are in phase of community transmission except India, where it is still no community transmission, and Russian Federation also. And total, the number of cases are nearing 4 crore cases, and last 24 hours, 3 lakh cases has been reported in global, and total cumulative deaths are more than 1 million deaths. And last 24 hours, 4,000 cases, 4,000 deaths has been reported. Among the active cases, we can see that there are around 8 million active cases are now there. Among them, 99% were in mild condition and 1% in serious or critical condition. And among the closed cases, 96% recovered, discharged, and the deaths were 4%. So we can say that the case fatality rate is around 4%. Now, when we speak about the different case fatality rate, Mexico has the highest number of case fatality rate, around 10%, followed by Ecuador, UK, Iran, France. US has a case fatality rate of around 2.5%, and India is among the lowest rate of case fatality rate of around 1.5%. So we have very low case fatality rate. Now to detect among different number of rising of cases and the number of deaths, we can see that the number of cases are still rising in the different WHO regions, and but mainly the cases are mainly rising in the Americas and the Asia. And in Europe, we can see a double peak. Firstly, in March to April, there was a slight increase number of cases, but the cases decreased in July. But again, the European countries, they are reporting increased number of cases. In Southeast Asia, the number of cases are slightly decreasing. We can see that the death rate rose sharply around April, May, but it has fallen down now, and now it is decreasing, and mainly it is stable now. This is about the total cumulative cases, but what about the cases per million cases? We can see that the cases per million, maximum number of cases per million person can be seen in Europe, South America, Russia, and US. We have an intermediate in India. We can see that an intermediate level of cases per million, around 101 to 500. We are in intermediate positivity rate. So in last week, we can see that the cases, new cases has been rising around 10%. But the truth is that the number of deaths is decreasing. Less than 1% is decreasing. Death rate is there, and among the Southeast Asia, including India, the death rate is decreasing. In America cases, we can see that the number of cases were highest during the July-August, but it has come down in September. Also, that death rate has come down in America. In Europe region, we can see clearly two double peaks. In March, April, we can see one peak of cases. And now, another peak has been occurring in Europe, Eastern European countries. In this, we can see the number of cases are increasing, but the death rate has been very less. In the second wave of the pandemic in Europe, the death rate has been very less. So we must not complacent in the scenario that the cases are decreasing, because we relax in this lockdown, and if we relax in these cases, we can see a second also in India also, like in Europe. What's over here? Move नहीं कर रहे. In Southeast Asia, and including India, we can see that the cases are have increased up to the September month, but from the middle of the September, the cases are decreasing in Southeast Asia, including India. Also, the number of deaths are also decreasing. That is a positive sign in Southeast Asia, including India. In Southeast Asia, mainly three countries that have the maximum number of cases are India, Bangladesh, and Indonesia. And all other countries in Asia are reporting very few cases, except Nepal, where the cases are increasing. In Africa also, we can see that a double peak. There are increasing number of cases during the July, and since then the number of cases has been decreased up to September. But again, there is slight increase in the number of cases and deaths in recent October. One thing the WHO has published is that what is the mortality rate and what is the number of cases among the healthcare workers. We can see that in March and April, May, the number of cases in healthcare workers were very high, around 25%. 20 to 25% were in April, May. The number of cases among them, the 25% were healthcare workers. But the good news is that since May, the number of positivity among the workers are decreasing. In July, August, we can see that the number of positivity in healthcare workers has been decreased. So overall, the WHO has reported that around 14 to 15% of all positive cases were healthcare workers. Now, there is some epidemiological difference between the patients of healthcare workers and other general population. In general population, we see that males are more affected than females, and the slightly older population are affected. But among the healthcare workers, it has been reported that females are affected more than male, because the WHO has reported that in healthcare, more maximum females are working. The number of female workers are more in healthcare workers. So proportionately, the females are affected more than males, and relatively, the younger healthcare workers were younger than the general population. Those who were affected were younger than the general population. So last slide is the among the community transmission and cluster of cases. We can see that all the maximum countries are in community transmission, like in European countries and American countries. But in India, it is still cluster of cases. But the number of case load is high, but still we are not in the community transmission page. So to summarize, we can say that the number of cases are increasing in all over the world, but the rate of increasing is less, and especially in Southeast Asia, including India, the number of cases are decreasing and the mortality rate is also decreasing in India. So we hope that this trend can continue and continue for the future. Thank you. Thank you. If you have any queries and any clarification, you can ask.
Hello.
Yes, please.
Yes, ma'am.
I want to ask, as you said, there is no community transmission in India. It's a cluster of cases.
Yes.
So what should be the number of the cases for the community spread?
It is,
Or what is the criteria?
It is, ma'am, actually WHO said that it is if maximum number of cases, positive cases, if they don't have any history of contact with any positive cases, around maybe more than 50% of cases, they do not report any history of contact with any positive cases in a large geographical area of the country, then we can only say that it is community transmission.
Okay, so in India there is still no.
Maximum number they are giving history of exposure to a known positive cases.
Okay.
But you have to do more surveillance in the community to know whether it is community transmission or not.
Okay, thank you. One more question. Like the second peak is evidenced in so many countries. So in India, so it's not very difficult to answer. The second peak is when is it expected?
No idea, ma'am.
No, as I
Ma'am,
said, there is a.
Ma'am, we have to see that whether the peak is decreasing now. We have to wait for a little more time, I think.
Yeah, and it should not be
Yeah.
our betterment.
Hopefully.
मैम एक्चुअली जब तक मैम एक सीरो प्रिवलेंस का कम्युनिटी का डेटा हमारे पास अच्छा नहीं होगा फ्रॉम अ फंडिंग बॉडी लाइक आईसीएमआर, तब तक कमेंट नहीं कर. अभी इस समय जो सीरो प्रिवलेंस के देयर टू डेटास, एक आईसीएमआर का मई का पब्लिकेशन है, तो तब जिसमें कि 0.7% पॉजिटिविटी थी, वो बहुत अर्ली प्री मैच्योर हो गया. उसके बाद मैम उसके बाद कोई बड़ा डेटा आया नहीं है. सेकंड इज जो एंटीबॉडीज बनती हैं, आर दे न्यूट्रलाइजिंग और नॉट, ये एक बहुत बड़ा पॉइंट होता है. तो उसका भी एक ही पब्लिकेशन है इंडिया से, एनआईवी पुणे से, इंडियन जर्नल ऑफ मेडिकल रिसर्च के रिसेंट इशू में है कि उन्होंने 100 कोविड पॉजिटिव पेशेंट्स में न्यूट्रलाइजिंग एंटीबॉडी टेस्ट करी. 70% हैड न्यूट्रलाइजिंग एंटीबॉडी एंड 30% डिडंट हैड. तो जब तक हमारे पास मैम स्ट्रॉन्ग डेटा नहीं आएगा, एक तो कि सीरो प्रेवलेंस कितना है और न्यूट्रलाइजिंग एंटीबॉडी कितने परसेंट पेशेंट्स में इंडिया में मिल रही है, तब तक कोई भी इस पे कमेंट नहीं कर पाएगा मैम. और प्रोबेबली इट विल टेक. इन लोगों ने सर्वे स्टार्ट कर दिया है जिसके रिजल्ट समवेयर नेक्स्ट ईयर अप्रैल में आएंगे. देन ओनली विल नो. या तो
सर्वे फॉर एंटीबॉडी
में.
Okay, but as I have seen in Meerut, though it will be practiced in all over India, there is a unreporting. So these cases are they are not an actual picture.
Means ma'am unreporting, मतलब clinical features are there and the test is negative, ma'am.
नहीं, test negative नहीं, they are not going for the right authority for the test. The people are doing at their home antigen test किया and they are home isolating. If they have any problem, then they hospitalized. This type of picture I'm seeing.
हाँ मैम, आप बिल्कुल सही कह रहे हैं. We get a lot of calls also. बहुत सारे कुलीग्स का कोई भाई है, किसी के जीजाजी एंटीजन पॉजिटिव आ गए, फिर क्या करें, अच्छा आइवरमेक्टिन ले लें, ये कर लें. मैम ये है, ये हमारी कंट्री का टिपिकल कैरेक्टरिस्टिक है, इसमें कोई कुछ नहीं कर सकता. Everybody is helpless.
Every person is a doctor.
हाँ तो मैम कुछ नहीं हो सकता. Chat
Okay,
में तो
thank you
question
very much. Very nice presentation, both of you.
Thank you.
Thank you,
Dr.
thank you.
Amit.
Thank
Quite informative. Thank you very much.
Thank you, ma'am.
Thank you.
Hello, sir. I am doing testing for H1 swine flu in suspected COVID patients. So the
Hello.
first question. Hello.
Hello. Good morning to everyone. May I question to Dr. Chinmoy?
Yes.
Hello.
Yeah, yeah.
Ha. Sir, can you tell me, are you doing testing for H1 influenza swine flu, or both the patients having similar presentation? As most of the patients, we are suspected COVID, and when we do RT-PCR in there, and it comes to negative. है ना? Even there is highly suspicion, inflammatory markers are raised, D dimers are raised, patient having post-COVID manifestations also. But in that case, RT-PCR is negative. Though I know that RT-PCR is not 100% sensitive, it has its own limitations. So, what do you prefer, to do swine flu testing in those patients also? Are you performing swine flu testing? And sir, what you suggest?
Ma'am, I'll take this call because I am concerned with the lab testing part. No, for swine flu, sample, if a sample comes for swine flu, then only we do a swine flu testing. We in otherwise COVID negative samples, we don't do a swine flu testing. Like because in SGPGI everything is paid. In fact, for COVID we are charging because it's an autonomous institute with a different set of rules and regulations. For testing, we are charging 1500 to our SGPGI patients. कोविड केयर फंड में कुछ होता है वो फ्री हो जाते हैं बहुत सारे, बट जो पेशेंट्स होते हैं जो कि हॉस्पिटल में दिखाना है, ये सब रीजंस हैं, उन सबका कोविड टेस्टिंग इज पेड. स्वाइन फ्लू टेस्टिंग भी यहाँ पे पेड है, उसके 2000 रुपीज चार्जेस हैं. तो इफ अ सैंपल कम्स फॉर स्वाइन फ्लू देन ओनली वी टेस्ट फॉर स्वाइन फ्लू, अदरवाइज हम नहीं करते.
अच्छा, नहीं आजकल आप कर रहे हैं, आजकल सैंपल स्वाइन फ्लू के आपके पास आ रहे हैं क्योंकि ये सीजन है, इट इज एंड ऑफ अक्टूबर.
आ रहे हैं. इनफैक्ट समथिंग इंटरेस्टिंग हैपेंड इन आवर लैब. हुआ ये कि सबसे फ्रॉम प्राइवेट वी रिसीव सैंपल्स फ्रॉम प्राइवेट हॉस्पिटल से भी आ जाते हैं कुछ, और पीजीआई के तो बल्क रहते ही हैं. सो दिस इंसिडेंस हैपेंड 2-3 टाइम्स. प्राइवेट हॉस्पिटल से कोविड नेगेटिव बाहर ट्रूनेट करा, उन्होंने कोविड नेगेटिव था तो स्वाइन फ्लू टेस्टिंग के लिए पीजीआई भेज दिया हमारे पास. अभी हम लोगों के पास क्या है, वो वीटीएम आते ही बाय डिफॉल्ट सब लोग कोविड लैब में दे देते हैं. ठीक है, तो वो बाय डिफॉल्ट जैसे वीटीएम आया, अरे तो कोविड का ही होगा करके और यहाँ पे टर्न अराउंड टाइम बहुत कम है, मतलब 8 आवर्स टू 10 आवर्स में हम लोग पीजीआई के सैंपल्स की रिपोर्ट दे देते हैं, क्योंकि 24 आवर्स लैब चलता है. जब कोविड पॉजिटिव रिपोर्ट आ गई, फॉर्म देखा तो देखा रही है तो स्वाइन फ्लू के लिए आया था सैंपल, इसका तो कोविड हो गया और वो कोविड पॉजिटिव आ गया. अदर वे राउंड कई बार हो चुका है यहाँ पे. और मान लीजिए अगर वो कोविड लग भी गया था, कोविड नेगेटिव है, तो हम स्वाइन फ्लू कर देते हैं. बट अगर कोई स्वाइन फ्लू के लिए आया है, कई बार ऐसा हुआ है कि कोविड पॉजिटिव निकल गया है, जबकि कोविड की 2 नेगेटिव रिपोर्ट्स थी उसकी, क्योंकि आरटीपीसीआर जो टेस्ट है वो काफी अच्छा है एज कंपेयर टू द ट्रूनेट और द सीबीनेट टेस्ट व्हिच इज डन इन अ प्राइवेट सेक्टर आउटसाइड.
ओके ओके. अच्छा, आजकल क्या लखनऊ में कोई स्वाइन फ्लू के केसेस रिपोर्ट हुए हैं पॉजिटिव?
लखनऊ के स्वाइन फ्लू में हमारे सेंटर से नहीं, पिछले 1 महीने में मेरे ख्याल से हुए होंगे तो 4-5 हुए होंगे, उससे ज्यादा नहीं हुए होंगे. स्वाइन फ्लू के वैसे सैंपल्स हमारे पास आते रहते हैं. स्वाइन फ्लू सैंपल्स हमारे पास योर क्वेश्चन इज वेरी रेलेवेंट कि रेस्पिरेटरी साइंस का पेशेंट है, 2 बार कोविड कराया, नेगेटिव है, तो नेक्स्ट थिंग द क्लिनिशियन थिंक्स इज स्वाइन फ्लू, और होती है इस सीजन में. बट सरप्राइजिंगली इस बार स्वाइन फ्लू मिल नहीं रहा हमको.
ओके ओके, थैंक यू सर.
हमको एक इंटरेस्टिंग चीज मिल रही है, डेंगी फॉल्स पॉजिटिव बहुत मिल रहा है कोविड पेशेंट्स में.
डेंगू फॉल्स पॉजिटिव?
हाँ, ये रिपोर्टेड भी अभी लिटरेचर में देखा था. तो जो कोविड एंटीबॉडीज हैं, दे फॉल्स रिएक्ट विद द आईजीएम किट्स जो कमर्शियली अवेलेबल हैं. तो आपको आप जो क्लिनिशियंस होंगे, आप कोविड पेशेंट्स को डे 10 पे फीवर आ गया, डेंगी करवाया, पॉजिटिव आ गया, तो उसको एक जस्ट correlated with the clinically with the thrombocytopenia and other things, क्योंकि इसकी ये नोन फैक्ट है. रिपोर्ट लिटरेचर में रिपोर्ट भी कम से कम 3-4 पब्लिकेशंस इसके हो चुके हैं कि कोविड एंटीबॉडीज गिव्स फॉल्स पॉजिटिव रिएक्शन विद डेंगू किट्स.
यस, ओके, थैंक यू सर, थैंक यू.
Any queries, anything else? Otherwise, we finish up the session. Thank you very much.
Thank
all
you
for
very
your
much for
time.
attending. Thank you for attending.
Bye.